Hi, it's Dr. Fox. Let's talk about the extraocular muscles. In this video, we'll discuss the attachments, actions, and innervations of the extraocular muscles. Extraocular muscles are muscles of the orbit which either attach to the eye or the superior eyelid. Most of them have their proximal attachments on bone or the common annular tendon within the orbit, which is located at the posterior aspect of the orbit. The distal attachments of extraocular muscles are largely on the sclera, or in the case of the odd muscle within the superior palpebra or superior eyelid. Any muscles which are attaching to the sclera of the eye are going to affect gaze. And very many of these, all but two, are going to have very complex actions because of the shape of the orbit. Keeping in mind that the orbit is an inverted pyramid, and we can see that the apex of that pyramid is going to move medially. And so most of the muscles are going to have actions which can be broken down into separate vectors. The only two which have simple actions are that of the medial rectus and lateral rectus, as we see. Now, all of these extraocular muscles are innervated by one of three nerves: the oculomotor nerve, cranial nerve 3, the trochlear nerve, cranial nerve 4, or the abducens, cranial nerve 6. So let's start with levator palpebrae superioris. Levator palpebrae superioris connects the apex of the orbit to the superior orbital plate. Its action's relatively simple. It elevates the superior eyelid. It's innervated by the oculomotor nerve, cranial nerve 3. There is one little slip of smooth muscle called the tarsal muscle, which is served by branches or sympathetic fibers from the superior cervical ganglion. That's why during a sympathetic response, the eyelids are wide open, ready for danger. It's also why during Horner's syndrome, one might experience ptosis, or a droopy eyelid, when there is an interruption of that sympathetic pathway. Now let's go to the muscles affecting gaze. Let's begin with the superior oblique. The superior oblique originates at the apex of the orbit. It runs through a cartilaginous pulley known as the trochlea before inserting on the sclera of the eye, just behind the superior rectus muscle there. In terms of its actions upon gaze, there are two. Its primary action is that of intorsion. Intorsion is when looking at the superior pole of the eye is going to move medially, so there's a slight rotation. The superior oblique also has secondary actions of abduction, so moving outward, and depression. Oftentimes, you'll hear this referred to as down and out, colloquially. The superior oblique is innervated by cranial nerve 4 or the trochlear nerve, which you can relate the trochlea of its tendinous pathway to the trochlear nerve. And it is the only extraocular muscle innervated by the trochlear nerve. Next up, we have superior rectus. The superior rectus muscle takes its origin on the common annular tendon, and it inserts it on the sclera, which we can see there. Its effects on gaze are also rather complex. Its primary action is that of elevation as well as adduction, owing to the shape of the orbit. So up and in. And its secondary action is that of intorsion, so moving the superior pole medially. Note both superior oblique and superior rectus muscles are going to have intorsion among their effects on gaze. Superior rectus, like many of the other extraocular muscles, is innervated by the oculomotor nerve, cranial nerve 3. Now let's look at the lateral rectus. The lateral rectus takes its origin from the common annular tendon and inserts on the sclera, which we can see there. It has a very simple effect on gaze, and that is of abduction. abduction. So it moves the eyes laterally or out. It is innervated by the abducens because the abducens abducts the eye, or cranial nerve number 6. Recall the abducens has a pathway that takes it through the cavernous sinus. So one of the earlier signs of a cavernous sinus thrombosis is that of abducens palsy, or weak abduction of the eye. Now we have the other simple action muscle, the medial rectus. The medial rectus takes its origin on the common annular tendon and inserts on the sclera. And when activated, it is going to adduct the eye, or move it medially, inward. The medial rectus is innervated by the oculomotor nerve. And it's one of the only extraocular muscles which you can bilaterally affect. So you can move both of your eyes inward, or adduct them, so as if to cross them. Next up, we have the inferior rectus muscle. The inferior rectus muscle, like many of the other rectus muscles, takes its origin from the common annular tendon and inserts on the sclera, which we can see there. Its primary actions include depression and adduction. So keeping in mind that both the superior and inferior rectus muscles are going to adduct the eyes. Its secondary effect on gaze is that of extorsion. So we take the superior pole of the eye and we are going to rotate it slightly outward. So depression and adduction, primary, down and in. Secondary effect on gaze is that of extorsion, moving that superior pole laterally. The inferior rectus is innervated by the oculomotor nerve. And lastly, but not least, we have the inferior oblique. The inferior oblique is going to originate on the orbital surface of the maxilla, and it's going to run over and insert on the sclera. In terms of its effect on gaze, its primary action is that of extorsion, so moving the superior pole laterally. Its secondary effect on gaze is that of abduction and elevation. And it is innervated by the oculomotor nerve. So one thing that you may have realized by now is that superior and inferior rectus muscles are going to adduct, whereas the obliques are going to abduct. So that's one of the ways that I can keep these straight in my mind. Anyways, thank you so much for your time, and I look forward to talking to you in the next video.